South Africa's health journey has faced challenges with siloed information, often paper-based system, and a lack of information flow between health professionals, funders, and health facilities. These barriers have significantly impacted the costs, quality, and access to healthcare for patients. In all of this, a need was identified. And today I'm catching up with Dr. Rolan Christian, CEO of CareConnect HIE, and Dr. Boshoff Steenekamp, Strategic Project Manager of Metropolitan Health Group, to talk about some of the exciting stuff happening in this space. Welcome, Christian and Dr. Boshoff. Briefly talk to me about the problem that led to the solution that you guys have came up with, and maybe mention if this is a private and a public health problem, and if the challenges in the public versus private space is slightly different.
Good. Thank you very much, Meet. It actually is an international problem. How to keep record of people's medical and clinical history in a manner that it is complete and that it spans your entire life. So that is a desire, and as a former practicing clinician, I have full understanding for the challenge. If you meet the patient, you'd love to know, you need to talk to the patient to find out what's wrong, but you also need to know what the other doctors thought and the other doctors did in the past, and what previous tests were done, and where you were hospitalized, and all of those information is needed. But to put it together as far as we've come has been a major challenge. I mean, it started more than 10 years ago, the first discussions between the founding partners, between Discovery, Momentum, NetScheme, Life, Mediclinic, and Netcare, to say, how are we going to create this absolute databases of shared clinical information that can be shared for a patient whenever he goes to see his doctor. Because it's not only the difficulty of getting competitors to collaborate, people in something that you don't have a direct financial interest in. There's no direct material interest, yet we collaborated on this manner because it serves the public interest. And then, of course, one needs to be cognizant of Competition Commission and the Competition Act. How do we collaborate without collusion? So there was some very clear guidance we got from Competition Commission at the outset on how to collaborate on this matter and how to share this information so we get going. And I really think it's a major feat of the founding partners to collaborate on something like this together. Thank you.
So you now know what the challenges are. So tell us about the solution that you came up with.
Thanks, Rianet. I think as Boshoff has painted the problem quite well, is that internationally, keeping these records in sync and keeping them from cradle to grave is the challenge. So what we've done is, starting at a point in time, we've got consent from the patient or the member to share their information with the Health Information Exchange, the HIE. And it's from that time they share the information at a hospital, with their medical aid scheme, with the clinician, that system of record is updated on the HIE and kept on the HIE until that person revokes consent. So we're very, very driven around the POPI Act and regulation around ensuring the patient has choice, and the choice is to keep the data on the HIE so it can be accessed by a clinician or a facility that patient could be visiting throughout his care journey. Like most of us, we go to the ER, or we go to our physician, or we go to a specialist in hospital, or we visit other facilities depending on our needs. Those systems of record, once consent is granted, gets updated to the HIE, and it's available to clinicians as and when needed. I think the important thing to note is that the data is kept in sync over the lifespan, which means that the quality of the data is always ensured, because you need high quality data to make clinical decisions. Also, that security around the data is of utmost importance, and those all ensure stability and security of the system, because we need to create trust amongst not only the founding participants but new participants, but also the patients and members themselves, to give them assurance that data will only be used for treatment, for their treatment, rather than for any other purposes.
Yeah, my next question was around POPI, and you've touched very nicely on it. Can you just exactly tell me when you have mentioned it, but I just think for clarifying purposes, when and where do people give the consent? So is it at the doctor? Is it at the medical scheme? Is it at the hospital? And is it explained to them? How is it explained to them that they are signing for something that their information is basically out in the open? I know it's not open, but out in the open for any medical person to have access to.
Yes. So Rianet, I mean, I think it's like you said, it's not in the open. The patient has to gives consent at the hospital. So as we've spoken about the 3 hospital groups, Mediclinic, Netcare, and Life Healthcare, on admission, they use the information, the HIE, to determine, all your demographic information, your clinical history that you could have had. And that information is then used in the treatment of a patient. So when you get to hospital, they are, it's informed consent. There's various documents and in some of the hospital groups, there's videos being shown in the sense of what does CareConnect mean? What does it mean to share your information? And why is it important to share information? Because it's about your care journey. And then on the medical scheme side, or the medical administrator side, joining a scheme, taking up a product, requires that information be shared with CareConnect because it's made available to the hospitals when you, for example, admitted. So, for example, like your chronic conditions, the medications you've been claiming for, which we assume you're taking, that information is of extreme value to the clinician dealing with you at a hospital side. So currently, the informed consent is given at the hospital side and the medical administrator side, and that information is kept very secure, very safe, and only used by clinicians in the corresponding facilities to use the information at point of care in terms of diagnosis and treatment.
Okay. Anything you want to add, Boshoff? I see these.
Yeah. Look, the consent issue is very, very important, and we're making very sure that we're up to date and we do apply it as well as possible, because it's always going to be an issue, and always people are very sensitive about their own health information.
100%.
And so we're very cognizant of that and dealing with it very, very carefully. Yeah.
Okay. Can or do you foresee that other providers will become part of this?
Yes, most certainly. It was founded by these 6 founding partners, but eventually the key players will be medical schemes, because medical schemes have direct interest in their patients, in their members' well-being, and they can do this and support this quite strongly. So I do think that will definitely be a part. And then we need to expand, and more doctors need to be put on, other hospital groups need to be added on, and other administrators who are currently not part, all need to be part of the thing so that we can build. Remember when I started off saying that the thing that we're striving for is a complete record of covering all providers and going, spanning your entire life. And so you need to get everybody on board to start playing with it, to get more information. For instance, at this stage, we'll get pharmaceutical information that use through claims, but all those over-the-counter medicines that are not claimed by a medical scheme are not included. So one needs to expand this gradually so that you could build that complete record.
Another very important question, and I think that will be on the in the hearts of many of my audience, and that is the financial advisor, is will it ever be expanded into life insurers having access to this? Because this can become quite a big story. If yes, because non-disclosure is quite one of the issues that we're still battling with, specifically in the life insurance and the rare disease and disability space. But I think it will create a bit of a issue there. But do you foresee that it will be expanded to on that level?
Look, certainly it needs to be considered very, very carefully because of all the matters that you've raised, and one needs to, and the point of departure is informed consent, so we can't, without that, you can't do anything in that respect, but it needs to develop much more maturely before one can actually do that meaningfully. So at this stage, it's something in the back of our minds, but it's definitely not up front, and it's certainly we have not considered that at this stage. So it is something that could eventually play a role, but it would have to be very, very baby steps, very, very careful, because all of these all the implications of this needs to be considered very carefully before.
Most certainly.
Rianet, I just want to add on what Dr. Boshoff was saying. I think we started off the HIE around informed consent by patients for treatment, for their treatment at any facility by any physician. And I think that builds trust between clinicians, providers, patients, members, and the entire sort of ecosystem that we're operating in, and a regulated ecosystem that we're operating. I think moving out of that ecosystem or that regulation would, we need to think very carefully about it, because are we improving the treatment of the patient? Are we bringing down healthcare costs? Are we ensuring effective delivery of healthcare? So I think those are our focus and our drivers. And I think once we achieve some of those capabilities and some of those KPIs, when we move into the life insurance, we've got to look at the same lens. How do we improve healthcare? How do we improve patient outcomes? How do we ensure healthcare costs are being reduced? I think if we use the same lens as we currently bring into other industries, it will ensure that trust and ensure that people are confident that their information is being used to improve their healthcare.
100%. And have you obviously don't operate necessarily on ground level, but have you got people that do not want to sign this? Have you had that issue ever?
Yeah, I mean, we've when we first started off the HIE, our consent levels were low because it was about in educating the public, informing them of the reason why we exist, what is the benefit. I mean, when we started off, I think we were about 30% consent. And today, I mean, at our event last week, Thursday, we unveiled we're about 70% at consent.
Okay.
So it's growing because there's trust, there's trust being built, there's informed consent. People are given information about the value it achieves. So I think that's been a testament to the process we've taken over the last year or so.
Does this mean that when I arrive at the hospital, I don't have to fill in those 500 forms anymore? It's all on a system, right?
Yeah, that's a good question. And I mean, it's a fascinating case study because one of our hospital groups specifically used the HIE to reduce paperwork, but mostly for the clinician, because there's, clinicians are running around with paperwork, there's cognitive overload. So there's been a lot of improvement in terms of clinicians optimizing their time. We do see that it's reducing paperwork on admission because they have, for example, they have your chronic diseases, they have what medication you take, they know what scheme you're on, they know your previous history. So that all helps the clinician, in treating you. And I do think over time, we will see that, when healthcare apps start using the HIE more, that information will be then pulled into the various processes like the hospital processes where, hopefully the paperwork will reduce by a factor of 5 if we're lucky.
Yeah, that was what that's the only thing I saw is less paperwork when you admit it, because that's quite a pain. You're supposed to have my information, right?
Yeah,
so,
exactly.
Yeah.
Exactly.
I'm skipping one or two questions. Talk to us about the public health system and the fact that everyone's data will basically be available to the state. So you're saying it very loosely, right? So I think, like I said, I think I should sound a little bit dramatic, but talk to us about this public-private healthcare story, because we all know what's the rumors in the background in terms of NHI, and people are a little bit concerned about that. So talk to me.
Could again so this is from the outset. The mission is to develop a health information exchange for South Africa. It's not just for the private sector. It's actually to be able to allow and enable the flow of data across the public-private divide. Because having previously worked in the public and the private sector as a clinician, sometimes you work in a public hospital and then you get information from private patient, and there's not enough information. And the same situation happens from private public patients going to see private doctors. So that information flow is critical for patient care. And it happens more than, I think it happens more than most of us realize, that type of need to share that information. So that has been the outset. And so we've been collaborating closely with the Department of Health in being part of the initial determination of those interoperability standards, because interoperability means you're not going to have one huge system. You're going to have many different systems, but they can interrelate and talk to one another. And that must be done in accordance with interoperability standards, which Roland will tell you a bit more. I'm sure he will tell you about how they've collaborated with the department in developing those guidelines, so that we can ensure that what we develop here can link up with whatever the state develops eventually, so that you could have that flow of information. And it opens up doors for reduce cost savings, improves the quality of care across the spectrum. And I do think that that's very important with that in mind, that it was not to try to be in another silo. It's the issue is to break down the silos and create one health system with the information flows.
I know my audience, that's why I asked these questions. Roland, you wanted to add to the interoperability story?
Yes, I think, we've worked very closely with the National Department of Health and some of the local departments as well. The National Department of Health's sort of standards and frameworks and policies, we do support them in the sense that it creates this interoperability. And I think it's a necessary foundation for universal healthcare coverage and whatever form NHI will take in the long term. And we've worked very closely with them to say, there's private sector assets and there's CareConnect as a asset for the entire country. How do we leverage that asset in the public sector? And we're working quite closely with the Western Cape Department of Health and National Department of Health to understand, we have EVDS, we have HPRS, we have all these capabilities in the public sector. How do we, like Dr. Boshoff said, how do we see patients moving between private and public? How can their health records move with them so the clinicians treating them have a better view of what's been done in the public sector or what's been done in the private sector as they move in between? So we're very excited to be engaging with the departments of health and trying to understand how do we work together collaboratively to bring about a positive effect for the citizen. So I think we've started that journey now with them, and we in the process of signing an MOU to understand what are the rules of engagement, what are the projects, and what are the benefits these projects will bring to citizens. So we're hoping that in the new year we can start these projects and deliver that value and showcase that at our next event.
Thank you for your time, Dr. Christian and Dr. Steenekamp. I really appreciate it. I hope our audience has got a better view of what CareConnect is all about. This is Rianet Whitehead, FAnews Editor, signing off.